Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario. We have Dr. Ryan Bailey that works with us at Safe Pet Anesthesia. And I'm Dr. Gianluca Bini, CEO and co-founder of Safe Pet Anesthesia, a training and teleconsulting company. And I'm also an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. All right. So whose topic is tonight? Ryan?
Yeah.
Nice. What you got?
Well, so I'll be honest, the inspiration did not come to me in the last, year or how long it's been since I've had to choose the topic. So I solicited some advice from friends. And given that, I thought, well, behind the scenes for the fucking viewers at home, we were supposed to record yesterday, but some extenuating circumstances arose and we did not. But yesterday I was busy with a bunch of projects, so I did not have a chance to come up with all the normal litany of crap that I do in regards to these topics. So my friend Gabby Escalante, also an anesthesiologist, gave me a great topic to discuss that I felt immediately stuck with me, and the amount of energy that it took me to come up with the ideas was low because they automatically just popped in my head versus some other ideas I was given that I would definitely need to do more research on. So, all right. Are you ready?
So what you got?
I want to talk about oral analgesic options, specifically for dogs and cats. And we don't have to limit it to orals, but I want to focus on kind of the outpatient analgesic options that we talk about. Maybe what we're recommending, what works, what doesn't work. Maybe we'll talk about some old favorites that are new again all of a sudden. Maybe we'll talk about some hot topics that people fucking hate. I just felt like it's this is an area where we're asked a lot of questions, and because of some of the workflow issues that we experience in our jobs, we are kind of advisors, but not always primary decision makers on that. So yeah, that's my long-winded wind up. So what do you...
Well, NSAIDs.
Great.
Easy one.
First, I'm going to say, I hate this question.
I know. As soon as she gave it to me, I was like, fuck.
It's the right question to ask because we need to address things where we struggle and where we hate, because that's really where you need to bolster knowledge. And the reason, just so everyone knows, I hate this question is because it's just very challenging because there aren't a lot of options and not all the options are as efficacious as I think we want them to be. So, and there's a lot of interesting opinions about things like oral gabapentin, for example. So yeah, this is a question I bump up against a lot. So it's nice to discuss it, and I think hopefully it will be helpful to the 4 people listening. But it's one of those things that kind of it's almost a little bit like oral sedation at home for fractious patients. It kind of makes you put your head down and give up a little, just because it's just all over the place, and there's not a clear cascade or delineation. And like Beanie says, NSAIDs, but I mean, I find even still NSAIDs upregulate people so unreasonably sometimes, and they will just strike it off the list at the tiniest little ridiculous reason. And it's such a important part of the spectrum of care. So yeah, good question. Good and bad question at the same time. Good, needs to be discussed. Bad, it's a challenging thing to discuss. Yeah. Beanie, you were saying NSAIDs before I casually interrupted as usual.
Let's cut to the chase, right? What options do we have, right? So NSAID is probably one of the mainstay, right? I think, as you said, yes, we do have a lot of, there is a lot of times reasons not to give NSAIDs. Sometimes it's probably, we may be too cautious, right? Sometimes. So, yeah, I mean, so in which instances do you think NSAID is a no-no, right? usually kidney, liver disease, right? Usually those are the two main
I mean, honestly,
most.
Beanie, I feel like everyone tars those cases a lot with the same brush. And I feel like particularly for us, there's more nuance to that. It's not just liver, because I think we need to talk a little bit about what that implies. Like, is there a sense that there's been some sort of liver irritation, or is it liver dysfunction? And if so, on like when is the scale appropriate? And it's the same thing with like, GI signs and if I have like a 19-year-old cat who has like chronic renal insufficiency, but is like in agonizing pain for a variety of different reasons, am I going to withhold a Medicam? No, right? Because it's a question of quality of life over like worrying about adverse effects. So I hate when people talk about NSAIDs in that way. Like, I don't give it if it's liver, kidney, or GI, and then we make ridiculous comments about things like platelet aggregation. And it really does, this is a specific area where I think we need to do much better, because the discussion really does need to titrate itself down to being more specific. And it's very similar, for example, like Dexmed and cardiac disease. Like, like, don't give Dexmed if you have cardiac disease. And it's like, oh, shut up. And that's exactly the same thing that I feel about the NSAIDs too. Like, you have to think critically through what is appropriate and what's in the best interest of the patient, more so than I find, for example, like so many people are like, I don't want to do that because I don't want to get in trouble. And I'm like, your job is to look after the patient, not after your own ass. So do a better job. So,
I mean, both technically, right? But anyway, technically it's both. But so yeah, no, I agree with you, and I tend to think so. I'm way more. Um, I rely a lot on sometimes on what actually happened during anesthesia. Like if I have a patient that's been hypotensive for a while, I tend to delay maybe the NSAID to the night rather than giving it immediately post-op. I know that some clinics, they tend to give it pre-op, which I think is kind of a dangerous game to play.
I mean, this is a whole other podcast.
Well,
Like, when should you give your NSAID? And I agree with you, Beanie. Like, I don't give it before anesthesia if I think that there's a reasonable potential to be a complication. And I have been burned so many times for acute bleeds that were unexpected, or for like ridiculous cases where you're a totally healthy patient that has like refractory hypotension for the whole anesthesia. And you're like, why is this happening? And you're just like, so unless you're like kind of what I would call like out of the woods, like for example, you're past the point where hemorrhage is a huge risk, or, we're at closure or things like that. Okay, fine, go ahead. But I feel like every 10 years, it's like, give the NSAID at the start, give the NSAID at the end, give the NSAID at the start, give the NSAID at the end. But like I said, I've definitely had my ass handed to me by things like the severing of the popliteal artery during a TPLO. And now we have an NSAID on board. The criticalist is looking at you like, you've recently had a lobotomy. And you're like, well, I mean, that's not supposed to happen,
Yeah, I think, in terms of MOA, pre-op makes sense, right? But the risk is so high that like I think that I rather play it safe and just give it post-op or a closure or when you're about to be done. I think the intra-op we can manage pain much better with many other things that you don't necessarily need the hand aids, right?
okay.
Post-op you're way more limited. So but
Bailey,
besides
when
that,
do you give your NSAID? When do you give your NSAID?
me.
oh,
Bailey.
Oh,
Beanie and I already agreed, so we're just going to wait for you to say something like Doppler.
are you my pet or are you my patient? Because it differs, to be honest. It's because I don't have the evidence to support my wild ass theory. But so my own personal cats who had dentals or whatever, they got NSAIDs the night before. They got it with like their Serenia and their sedatives, and they got their Onsior the night before.
Okay.
And one of them had. So I think the one actually didn't get it the night before. I like scoured my house to find a dose of Onsior, but I did not, or robenacoxib, whatever. I did not have an available dose for him, so he did not get.
Why did you sort of like random like NSAID just scattered through your house? You're just like
Well,
bills, Onsior, like.
I mean, I just, I make sure I have medications for my pets. So if they have to go to the clinic, I have some sedatives so they're not assholes, because one of them is a real bitch. And I thought maybe I happen to have a dose from her dental procedure where, she had some NSAIDs for post-op pain. And then I think actually I will actually say, when he went to the clinic, one of my requests was, well, before his anesthesia, I was like, if you have oral Onsior, can you give him a dose before we get started? And so that comes from what Gianluca said, the mechanism of action. We know it's going to be working before the procedure starts. B, there was a older paper that showed patients who were on oral NSAIDs had much lower pain scores, no matter what pain medication plan they were administered during a TPLO procedure. And so one of the journal club discussions we had on that paper was whether the oral NSAIDs had actually helped with the pain they were experiencing. And so it didn't matter what pain options you chose, like HLK or epidural or whatever. And then this is where we're starting to really get out there, is there's been a couple, I'm just going to say, controversial papers and discussions within VA and at our larger lecture series conferences, in which there has been question about the use of parenteral injectable NSAIDs, and the rates of acute kidney injury that are reported. There's some speculation out there about, are we seeing the same rates with oral medications versus the parenteral medications?
Gotcha.
So
what was the conclusion of that conversation? Because I'm curious to know.
What's that?
What was the conclusion of that conversation?
There is no conclusion. There is no conclusion at this time. The conclusion is more research needs to be done.
Right. Okay. So that's useless.
What's that?
So that's useless.
What, the conversation?
Yeah.
I mean,
totally useless.
You have to start somewhere once again.
Right, sure.
So in my patient population, if they're on NSAIDs, great. If they give them orally, I'm not going to sweat it. If they have not gotten them orally and I need to decide, I'm going to recommend, out of an abundance of precaution, based on, as far as I'm aware, actual evidence to support this claim that we all practice, I will administer them after anesthesia, assuming it all went well and we did not experience a hypotensive crisis.
Yeah, I think that most of it comes from, the increased potential risk of acute kidney injury if you have the combination of hypotension, prolonged hypotension, and NSAID administration.
But is there evidence? Show me the evidence. I know the mechanism is there, and I know the theory is there. I believe all of that, but show it.
No, I understand that. But how many people in VetMed are actually looking for acute kidney injury, right? In humans, we do not send the people home till they pee after anesthesia, right? They want to make sure that you're not in that anuric phase of AKI, which is the very first phase of AKI, right? In VetMed, we ship the dog home or the cat home 2 hours afterwards, whether they peed or not. The owner is not instructed to even look for pee or for urination or not, right? Half of the time, if you read the discharges, nobody, I can comfortably say that I've never seen anybody write on a fucking discharge, monitor for urination, right? Yeah. Have you?
No. I'm in agreement. I think there is.
Nobody.
You're preaching the choir.
For each other. Have you seen it? No. Okay, but that's fine.
Anyway, so also,
by the way, has nothing to do with oral medication. So we are doing a tip-top job here.
Oh yeah, we're totally diverging in a fucking rabbit hole as usual. But basically, but that's the problem, right? So these studies are almost impossible to make in veterinary medicine. We're shitty at follow-up, right? Somebody comes in, a specialist center, they do anesthetize that pet, they send it home. If 6 months later or a year later that pet has CKD, God knows.
Right.
Nobody follows up a year later or 6 months later. God knows. Also, we get blood work way less often. Our patients, right? Maybe they come in, they had surgery, they go back home, they go to a regular vet, maybe couple of months later, they do not get blood work till 1 or 2 years later down the road, right? Like, so the frequency that our pets get checked at, it's way lower than humans are.
Mm-hmm.
And so all of this contributes to the fact that these studies are almost impossible to make. And that's why in 20 or 30 years or more of literature, there isn't one.
Yeah.
Because
Well, I think we need to be careful, because what I don't want to have happen is everyone starts checking blood work and then blaming us.
I mean,
I don't need to hear about CKD 6 months down the road, and that also get tagged to anesthesia's problem list. So
sometimes it is like, why do you think all these cats out there have chronic kidney disease?
thank you. I was like, and here's I'm going to jump in with my other crazy theory. That the reason cats all have CKD is because they're also fucking hypotensive under anesthesia, and no one manages it correctly, and they're all developing AKI multiple times at these stupid fucking dentals, and that's why you see all this CKD in cats.
Well,
you guys just did exactly what I told us not to do. Not that you're wrong, but I was like, from a political standpoint, we really just shot ourselves in the foot, guys.
Okay, I think that more than the dentals, which I agree that sometimes
it's just the most common repeated anesthesia event for these patients.
I think that most of the damage is made as spay and neuter. Because
I think there's consistent damage though through time, but I do absolutely agree with you. I think there's a major hit there, and then I think there is additional subsequent hits in additional procedures, because cats are just they're so frustrating.
Fair. And let's make it clear, if some pet owner is listening, this isn't a dental with, we're talking about people that do not monitor their patients appropriately, or they do monitor them but not take the appropriate interventions. Okay.
Yeah, absolutely.
So we're not talking about the specialist that has the anesthesiologist or that has a service that monitors the anesthesia or whatever.
Yeah, to be clear, we're not talking about us three.
No, but us, any anesthesiologist would not let something like this pass.
Well, I live in hope that is a true statement, but I definitely want to be like, it's not the three of us. Yeah. Mm-hmm.
Okay. But, I think that the major hit really comes at, spay and neuter, with the excuse of being a relatively short procedure in the 20 to 30 minute range.
In a healthy patient.
Who
has reserves.
There is clinics out there that do not monitor blood pressure. And there is clinics that if they do monitor blood pressure, they don't have a way to fix it.
Yeah.
Right.
Listen, and so clinics out there who send pets home with comminuted fractures and no oral medication. So,
and they may or may not be intubated, because the evidence suggests that intubating a cat can lead to higher likelihood of complication. In a very old paper that still gets
one paper
that still gets dragged out from time to time.
Yeah. Okay. So long story short, there's people out there that do a bunch of sketchy shit. And that's why a lot of the cats do suffer kidney damage.
Like the people who fucking give their own cats at home their, around NSAIDs.
And that's Ryan Bailey for you guys.
And back to our conversation about oral meds.
Martel, when do you give your pets, when do you give your patients their NSAIDs, and how do you manage that?
I'm the same as Beanie. I like to clear the air, but you should also know that my cat has been on daily meloxicam for over 3 years to manage chronic DDG and OA.
Exactly.
I could not have more perfect renal values, probably up until this afternoon, but that's for a whole other reason. So, yeah, BW got diagnosed with carcinomatosis this afternoon. So, yeah, it's okay. But yeah, no, my cat's been on NSAIDs for years. The one who swims.
So Brownie.
No, Brownie's fine. Brownie's just a diabetic and an asshole, but BW is the one who goes swimming and is on all the videos.
No.
Yeah.
Okay.
But anyway, so yeah, that cat had been on meloxicam for years on a daily dose just to manage chronic degenerative joint disease. So I am not. And the other thing too is, here's a quick question about NSAIDs. Do you guys always perform blood work, for example, before you recommend or prescribe an NSAID?
Well, usually because
would you consider that standard of care or a best practice? Because I feel like it's a little old school in my opinion, but I don't know. Where do you guys land?
I don't think outpatients you need to, but like, in terms of like, probably our field of work, I think usually our patients do come in for a procedure and then they get prescribed an NSAID afterwards. So they do come in with blood work, not because of the NSAID, but because of the procedure. So
Mhm.
like, that's that's my answer there. I don't run a pain clinic, so I don't know if I would have her lean that way. I don't know what you think, Ryan.
Yeah, so I think in our in our patients undergoing anesthesia, I think it's a bit of a different story for sure. So I think, yes, recommending blood work in those situations. I think, from my opinion, as a veterinarian, knowing the incidence of acute kidney injury in our pets and our ability to treat those patients with what ends up becoming chronic kidney disease being somewhat limited, species dependent for sure. I think it behooves us to at least inform owners of the risks of this, the potential for risks of this drug, and inform them of the options to mitigate those risks. And whether they want to go through with that is up to them, as long as they have the informed consent. But I think it's in our best interest to provide what we think is best for the patient, taking into account all of those risks. So here's a good example. You have an old crunchy cat who, like, has a little laceration, and you maybe want to prescribe an NSAID, but the owners don't want to do blood work. I think that one you have to weigh a little more heavily than the young healthy cat who has a laceration and you want to prescribe an NSAID. I think you can be a little bit more liberal if the owners don't want to go forward with blood work, just kind of assuming a little bit of risk in those two different populations. Now, in a dog, I think general rule of thumb that I would follow is, like, if they don't want to do it, it's probably okay to go ahead with it. At the same time, though, dogs who develop CKD don't have the same levels of like, I don't think they have the same like survivals that cats do, because cats get CKD and then they live for fucking ever. But dogs that develop like kidney injury and CKD, like, time's ticking, and so, like, if you do contribute to that, like, that is not an insignificant thing in dogs. So I think that's something to weigh for sure. So I don't it's not, to me, cut and dry, but I do think we should be a little bit more liberal with our NSAID use personally. That's
I,
long-winded.
I,
So
I don't think you should be afraid to say that. I think we're, like I said, I think we're far too like uptight and
Oh yeah.
judicious about it. And I think that constantly running blood work, like, it can be cost prohibitive, and also, I'm not sure what the value is. My next question though is, like, how many times have you guys incurred in your clinical experience, like, an actual case of AKI that you really felt was directly related to like that recent anesthesia in which you were involved?
to
Okay,
be honest,
but I would have predicted it before the patient even came out of the case. You know what I'm saying? It's like this hypotension that's intractable. The patient came in septic shock, that was not adequately resuscitated prior to anesthesia because of time slash, the disease process. It's like, I'm doing
yeah,
the best I can, but I'm sure I'm not going to prevent AKI in those cases.
yeah, yeah.
Okay. Yeah, I've
So,
only had one case, however many years, and it was exactly that type of scenario. Like, you had to go, the patient wasn't optimized, it wasn't stable, but it couldn't be stabilized without surgery.
yeah.
And it went in already on sort of the cusp of AKI. And I was like, and it was, a crappy anesthesia. And I was just grateful to get it off the table. But the criticalist and I knew, like, tomorrow, like, we're going to be managing AKI. But that's once out of over 10,000 cases. So my question is, are we too worried about AKI?
Yes. But at the same time, like, AKI isn't a death sentence. I mean, it can be for sure. Like, if you become all uric and anuric, it's for all intents and purposes a death sentence.
But
But at the same time, there are probably a large amount of patients that are developing acute kidney injury that goes undetected because we're not looking for it, and it resolves because the kidney does have some residual, like some robustness, that it can have some cell death and not be, a disaster.
yeah,
What do you think?
I don't think we're too worried about it. I think we're not looking for it. I think
Okay.
that the extent of your case was probably worse than we're talking about AKI, but like in general, like it's not the whole kidney that gets damaged, right? Like, there is a portion of it that gets damaged.
Yeah.
Like it doesn't happen all, it's not a whole of nothing kind of thing, right? So I think that the extent of the AKI also matters, right? And probably the situation where you have a septic patient or something that, vasoplegic or whatnot, of course, the damage that will be done there is way different than, and again, I'm not condoning who doesn't measure blood pressure and does not fix blood pressure, but then the 15 or 20 minutes in an otherwise healthy cat that goes under anesthesia for a spay, and the clinic is doing a shitty job at it. Okay. So like, it's probably a very different situation, right? And the extent of the AKI is going to be different too. One thing that I was, going to mention is like, so we've been talking about NSAIDs the whole time. I think that some people also forget that steroids are a good option for analgesia, right? Like, there is patients that cannot get an NSAID, but you could use steroids, right?
Gianluca, you're on it today. I just want to say that. I was already, first of all, I was like, we gotta move on. We gotta have some final parts on NSAIDs here, and we gotta get to the next topic because we're gonna spend an hour on NSAIDs. And had I known we could have spent an hour on NSAIDs, I would have been a lot lazier, let me be honest. But why are we not using steroids? Why? I used to offer them all the time in my previous shop and be like, oh, you don't think it can have an NSAID? Well, how do you feel about a dose of steroids? Or how do you feel about a short course of steroids? And I might as well have been like, let me get out the axe and murder the patient in front of you. Would that be okay? Would you be okay with me doing that? I could not for the life of me figure out the aversion to using steroids, like a short course of a steroid, like a week or whatever.
I think there is a lot of aversion on steroids, right? Like, and I think that people sometimes, they mishandle steroids, like dosing, right? They go with way higher doses than, they don't understand that the analgesic dose is lower than the anti-inflammatory dose, which is lower than the,
immunosuppressive
dose, right? So like there is different dosing levels and there's different effects at different doses. So, and there is different side effects at different doses. So the side effects that you get at the immunosuppressant dose, it's way worse than what you can get at the anti-inflammatory and or the analgesic dose. So every time that people think about steroids, they think about, delayed wound healing,
PUPD,
all sorts of side effects. Yeah. PUPD.
Question for you guys about steroids then. Like, I mean, steroids are monster analgesic in human anesthesia, right? Like
steroids and NSAIDs, that's like a common thing for humans to go home on.
They're much more reticent about opioids than we are, but
for good reason.
How do you feel in terms of like the anti-inflammatory capacity of an NSAID versus a steroid? Which one do you think is more efficacious?
Oh, steroid.
Steroid.
Okay. Based on what?
Yeah, that's a great question.
Based on what?
I mean, at least the mechanism of action for sure. It works higher up in the chain.
Yeah, and I think it works on way more being an endogenous. Usually you do release your own steroids, right? Like so, I think that it hits on way more.
So based on basically like clinical reasoning, but we really don't actually know the answer, do we?
Yeah, I would say that's a fair.
I mean, because I will say too, in the last couple of years, right? Like for example, if you're doing something where you have like concerns about airway inflammation, I've had a lot of long conversations about should we give the steroid or should we give the NSAID, and which one is really more efficacious in terms of anti-inflammatory. There's some newer specialists coming out who are really driving the NSAID conversation versus the very rigid old school mentality that the NSAID is really the more potent and anti-inflammatory. And personally, I don't have the answer. And I've done both. And sometimes I've done both together because it's been a real fucking shit day. But I don't think there is an answer unless I have completely missed the plot.
The only caveat
which is
The only
possible.
caveat I want to put on what you just said, Bartel, though, is like, is that conversation coming from the like delayed wound healing, increased dehiscence kind of conversation, aversion to like it's an aversion to steroids and choosing NSAIDs in that situation versus
I
like,
don't have an
you know
answer
what I'm
to that,
saying?
and it's possible that maybe that was the background thought process. It's not
Yeah.
been like the forefront of the dialogues that I've sometimes had.
Oh,
Like
for sure.
a lot of the surgeons I worked with in Singapore, like we sort of sat there and it was like, well, which one is better? So which one
Right.
should we give, right? And sometimes if we had a like low indice of like, indices of risk, maybe we erred on the side of the NSAID. If we were really confident that the Frenchie was completely going to have to end up like having a trach, we would err on the side of the steroid. I've had that before where I've given the NSAID for something totally unrelated. Like I had a polytrauma once who then its entire neck swelled at extubation. And then the criticalist was furious because they couldn't give this steroid. And I was just like, well, technically you can give them both together, blah, blah, blah. But I don't think there is an answer. And nobody really asks this question.
Yeah.
How can you tell though? I mean, like just a
Well, that's
silly.
another. How do you quantify the degree of anti-inflammation? Like you can either stick a tube in its trachea or you can't.
Right, for sure, for sure. Yeah, I never got a lot of buy-in on using steroids, and I never, like in the patients that I saw as primary, I never really had occasion to recommend switching to a steroid for those guys, just because most of them were like osteosarcoma cases, and I felt an NSAID was the better choice for those guys. But like, I'm sure I was seeing a different kind of pain patient for a different kind of cancer. I feel like maybe I would have pushed for a steroid in those situations.
Which is nice because you can give orally, right? Like you can send them home. And steroids are cheap and cheerful. Now, I do get that. I've had patients before that they have gone home on oral steroids. And like, it's interesting because like their side effects are so marked, like they just go from zero to just like just uncontrollable, like urination all around the house. And the owners are like, look, like if this is the answer so that my dog has better longevity for the next month, then I'm just going to stop altogether. So I don't know. I find, we're sort of relaxed about the side effects associated with steroids. And it's probably because they don't incur like something as potentially life-threatening as like a duodenal perforation, theoretically. But, I think from the point of view of the client and the client pet relationship and how that's actually impacting the longevity in terms of the pet, I think we do need to maybe have a little bit more careful consideration about the steroid.
Yeah, and there also is an owner aversion to steroids at times because the side effects in humans on steroids can actually be quite severe, and so some people quite
They get
averse to
rage. They get the steroid rage. They can get incredibly edematous. Like it can be very challenging. I had a lot of friends who had to take steroids associated with like chemotherapeutics when they went through cancer treatment, and like they reported that sometimes like the steroids were the harder one to endure. Like they couldn't sleep. Like they, like it was just like they were just manic all the time from the steroids. So. But yeah, oral meds. So check on steroids, check on NSAIDs. What else?
How about Trump?
How about
tramadol? How about tramadol?
Right.
Tramadol is currently it's in the shit house, right? And I feel like we've totally like tossed it out.
What species?
Well, that's a great question, right? So I think it's in the shit house for most of them, but I still think that it has its place. Do you guys agree?
In the patient's eyes.
Go for it, Bailey. Go for it. Sorry.
No. I like how you asked the question and then you started to answer your own question before you gave us. Usually I just notice kind of a give and a take with you. You're like, I'm going to give my long-winded question about this and then let you go into it. And you just had so much to say you couldn't hold back. So,
I mean, to be fair, earlier, Gianluca did ask you a question and then answer on your behalf. At least in this case, I just answered my own.
Oh my goodness, you guys.
I don't know, tramadol. What do you think? Like, I mean, cats, for example. How do you feel about tramadol in cats? Because they're a lot more interesting, in my opinion, than dogs.
Thumbs up.
Yeah.
Double thumbs up, in fact. I mean, the evidence is there that it works if you can get into them.
That's but like, can you get it in the cat? Because tramadol tastes butt.
I mean, you can use like a pill pocket, or you can get it compounded, or there's the little tiny tabs or whatever. Although, like, I have some really strong feelings about cats and like pain management options. I know, like, what a shock. Bailey has weird opinions on cats, but like for cats, like oral medication. Fucking, why are you orally medicating your cat? There's so many more options for cats of drugs you can give them that have prolonged action that don't need to be administered, by mouth.
You're
Such as,
talking about fentanyl patches?
No.
how about a lidocaine pad?
I mean, you got Zorbium, you've got sustained release buprenorphine.
No. Let's rewind. So let's talk about fentanyl patches, Ryan.
Well,
Technically not oral, so not really on the purview of tonight's conversation.
no, it was. I expanded it. I said it is outpatient analgesic options.
Oh, okay. Sorry, I wasn't listening as usual because I don't care.
Shocking.
So what's your thought on fentanyl patch? Because that's a long-term, analgesic option, right?
For sure. I mean, from clinical experience and from my understanding of the literature, they are trash, and they should generally not be recommended to patients available to them, is my opinion. The absorption is erratic, if at all, at least based on, the pharmacokinetic studies, which, I mean, we're relying on the drug to get into the body. So if it's not getting into the body, what is the fucking point? And then
I love listening to Bailey always try to be diplomatic and then just unraveling. Like, that's one of my favorite things where he'll be like, look, I just, if there's no other option and like, it could be
I mean, there are probably patients that we need to think about it for, and like it's probably the last line, and like it's an it's like I can tell you, I had a dog growing up. He was on tramadol. The tramadol seemed to help him. This was before I knew anything about these things, and like there are probably some patients who have an altered pathway, and they make the ODES methyl tramadol, and it works for them. It's just unpredictable in dogs. Cats, everything else, they're fine. Give them all the tramadol you want. Doesn't matter. But the fentanyl patch, like, it just doesn't seem to absorb because their skin is just different than humans. And so we don't get plasma concentrations. And then the ones we do, they all get fucking manic as hell. And, like, you tell the owner to pull the fentanyl patch off, and the dog is, like, right as rain and everything's fine. And, like, was that beneficial for the dog to be, like, screaming at home and, like, bothering the owners and anorexic and this and that? Like, that's also probably not beneficial either.
I mean, I feel like, depends on the patient, right? There are some patients that do well on it, some patients do not.
Sure, yeah.
Yeah. I mean,
and what I say applies to, like, when obviously I'm the one who's like, well, the paper says this. And it's like, I'm choosing to look at it as like a population level. I'm not thinking 5%, I'm thinking 95%. I'm thinking, what are the chances of the patient in front of me responding well to this medication or poorly to this medication? And I'm going to take the good odds and not the, like, 5% odds.
fair.
I'm looking for a horse, not a fucking unicorn.
So, riding the wave of topical stuff, right? Like, what about Zorbium?
I use it a fair bit in my previous job. I got burned quite a few times, absolutely, for sure. Like, some of those cats got manic because cats and opioids are not always a good mix. And it sucked, for sure. I used to be pretty militant about, like, no buprenorphine for cats before a surgical case, because what if we want to do this or that or whatever? Like, what if we want to use a pyramid agonist? And then I totally relaxed because the evidence for cats is continuing to mount about pyramid agonists not being the hot shit we like to think they are. And so I tended to be like, oh, well, the cat's got buprenorphine, like long-acting buprenorphine on board, so we'll be copacetic, essentially. But there were definitely some cats that got manic. But I also think for owners, it's just such a gift if they don't have to, like, orally pill this cat. Because, like, let me tell you, as an owner of 2 cats, one of them, that cat is as dumb as a rock, and you just put the fucking churu out. I gave him, like, a massive, like, like dog-sized trazodone for him, and he just like slurped that thing down like it was nobody's business. Carol's like, "How are you gonna eat this horse pill?" And I was like, "Don't you worry." And he just fucking took it like a champ. The other cat, if I have to orally medicate her, it's like honestly, I'd probably have to consider like I don't know.
Anesthesia and a stomach tube?
Yeah, exactly. Because like it's just there's no like getting oral medications into Lucy is like literally hell.
I think the other thing that I also find that a lot of people, like in terms of compliance, can be a limiting factor is the number of oral medications and also the frequency of the dosing, right? Like, God, I mean, same thing with me. Like, first of all, the chance of me oral medicating Brownie is the chance of me launching into space and discovering a new planet. And then if I were to go home and have like 4 different medications and one's at 12 hours and one's at 8 hours and whatever, I would never see that cat again. That cat, I would never see that cat again. And if I did, we would have full on scale warfare. And I'm not sure in terms of quality of life for either of us. I would be like, I need another option. Now, I can bring home needles and do my own injections type drama rama, but most people cannot.
Yes.
So, when they go home with one of the, like those brown bags full of like 95 medications, I'm like, what do you think the odds are that they're going to actually A, get that done, and B, finish the course of treatment? Because I just think it's so impractical.
I think about that. I would see all these cats go home and all these like pill vials, and I'm like, who are you fucking kidding? That cat got one pill.
And we all have like these tricks. We're like, well, I'm going to put it in butter and I'm going to mix it in tuna sauce. And I'm like, cats, you can get away with it one time.
Yeah.
And then they'll be like, oh, I'm not falling for this shit again.
Yeah.
Right? Like
these fuckers tried to fucking poison me.
So okay. But on the Zorbium side, right? I think that there has been a bunch of reports of cats that got overly sedated on it.
Oh yeah, I think that's true too. I mean, I also had a rule of thumb: only the big Zorbium, no matter the size of the cat, and like because every cat to me is 5 pounds, and so it was
you would always
5 pounds or 5 kilos.
Like or 5 kilos. You're right. Sorry. Like
because
it's over 6 pounds was the dosing, so like the big cats didn't get any more.
Wait,
you know what I mean?
Let me figure this out. So there's 2 dosing of Zorbium, right?
Yes.
The low dose
under 6 pounds, which is 0.4 mils, or 1 mil, which is 20 milligrams, which I also don't understand, but that's like a further issue.
So you were giving small dose to everybody?
No, I gave the big dose to all adult-sized cats.
Jesus, right. Okay, so I have clinics saying the opposite, right? They give the small dose to everybody because they don't want to overly sedate them, right?
Well, is it better to overly sedate them or underly treat them too? Because this is one of my pet peeves about buprenorphine in general is that people give these bullshit sub-analgesic doses clinically to cats who've had major therapeutic intervention. And I'm like, what are we trying to achieve here other than make ourselves feel better about dumb decisions?
Yeah.
Do you give Zorbium, Beanie?
Do I give Zorbium?
Yeah.
No, usually, that's not something that we... I mean, unless a clinic asks for
me either. So I'm pretty sure we're going to get some Zorbium sponsorship for the podcast.
I will say, I do know about the sustained release, the Symbidol, the sustained release,
the
injectable one. I do know a fair number of reports about that causing a degree of sedation that was not really appreciated by anesthesiologists, and so they tended to dose down and found it to be a better balance of like sustained analgesia. But that one also never made sense to me because it's just like a big old dose. It's not a special molecule, so like I have some opinions about that, and I'll just keep them to myself at this moment.
That makes for a pretty interesting podcast, but yeah, opinion yourself.
Well, we haven't even talked a bunch of them. What about acetaminophen? Because that's the new thing that's sweeping the nation. It's the new old thing. It's old, but it's new again, and everyone loves it.
New in this continent. Everybody else has been on the paracetamol. Like
I get a million questions about it, and I'm like, I'm unprepared to answer that because it's an institutional specific thing, and I wasn't an institution specific to it, so I can't answer that question for you, unfortunately.
Yeah. It's only new in North America, right? Like the EU, the UK, Australia, New Zealand.
Oh, yeah.
Yeah, they
parts
were
of
using.
Asia, like they've been all on top of that situation.
We had
So
injectable. They call it paracetamol.
Yeah.
We call it acetaminophen.
Yeah.
But I mean, we had injectable all the time in England. You know, it wasn't a. But I mean, I think it works.
do you
What are
think it
your
works
reasons
as
for
a
it?
standalone though, Beanie, or more as an adjunct?
As an
Because certainly
adjunct, you know,
the
without it.
literature is not super fan of the efficacy of
It's true.
paracetamol as first line or as a standalone. I often use it in addition to something else. But I
Yeah.
mean, as a person who suffers from migraines, Tylenol ain't getting the job done, let me tell you.
But what about those patients who maybe you don't want to use an NSAID? Would you feel more comfortable using acetaminophen, paracetamol in those patients? Are you worried about the same kind of high risk giving it? If you work in a place where you have the injectable formulation, because like in humans, you get injectable paracetamol, I think quite commonly before major surgical procedures, if I remember correctly. And so like,
I'm not worried about AKI.
yeah,
The risk with Tylenol or acetaminophen, it's more on the liver side than on the kidney side.
yeah,
So in patients with liver disease, yes, I am worried about Tylenol too, right? But and again, depends on what kind of level of liver disease we're talking
right,
about. If
for
we're
sure.
talking about dysfunction or we're talking about mild elevation of liver enzymes, like who gives a fuck, right?
Yeah.
But I think Tylenol definitely can be used more quote unquote freely
Yeah.
or with less risk than NSAIDs in some cases.
As long as they're not.
Correct. Not
I knew you were going to say that.
I mean, we should just clarify for the people
that's
who don't have
The
love
dog
and dog
thing.
in front of them and don't remember everything about acetaminophen that is not for
that is
use in
correct.
cats due to
That is
isn't that a methemoglobinemia drug for them?
Mhm. Yeah.
Well, there's a P45 cytochrome limitation that then drives up your plasma concentration, and that's what perpetuates the toxicity. Okay, that's fine. It's fine. You don't care. Yeah, I'll shut up.
What about amantadine?
Oh, did I use it? It was always in my arsenal. So let me tell you, I had a pain clinic. I saw maybe 10 patients. The majority of them were osteosarcoma.
Total in your lifetime or a day?
In like the time I was in the job, like that was the
Yeah.
amount of patients, and it was almost all osteosarcoma patients who didn't want to amputate, who had seen the surgeon, who then referred them to see me to talk about pain management. And the first step for me was unravel their like pain medication history and talk to them about like what I viewed as a entry level pain management plan to start this patient on so we could get like some good baseline information about what works and what doesn't work before we start throwing the kitchen sink and the owner has 1,000 fucking pills to give the dog. Yeah. So it was always mentioned as like, I think I chose amantadine was often a second line drug. For most of it was like, well, let's get you on like a regular non-steroidal anti-inflammatory drug and let's talk about how we're going to utilize opioids. And then a brief discussion. I will say I did in those patients, given the type of disease process they had, I did recommend gabapentin, but also did add the caveat that like it can be hit or miss, and some patients absolutely love it, some patients absolutely hate it, which I also learned when I was at the human pain clinic. Some people think gabapentin actually changed their life, and some people are like, this is the worst drug I've ever been on, and I never want to take another pill because I feel like I'm in a fog. So that's where I started personally.
So amantadine as an adjunct, probably okay, not first line. Okay.
Yeah. And
How about
the
oral?
evidence for amantadine that's stronger, I think, was amantadine combined with an NSAID for pain. So
I think
that's
you forget though, which is like something important too. Like your first dose of amantadine is unlikely to really have any analgesic efficacy, right?
absolutely. Absolutely.
Also
Yes,
true
well,
of gabapentin, right? Like people like they start dosing it right away, and I'm like, well, let me know in 2 to 4 weeks when that kicks in. I think building to effective plasma concentration for your analgesic threshold is an important consideration. So you can't just jump the gun with amantadine. I happen to like amantadine very much as a chronicity, as an adjunct, and I really sort of push the dosing label limits as well. Like, it's supposed to be 5 mgs per kg per day once a day, but there's some more evidence coming out that if you do it twice a day, like Q12, and like you can go up on the dose, and like I will edge them up, particularly for in that specific instance where if you have like multifactorial complex neoplastic pain, and it's really at this question, it's 100% palliative, then I really don't give two shits about that
Right.
dosing, right? So the safety margin for the NMDA receptor antagonist is enormous, which is why I
Right,
feel
right.
comfortable in doing so, just so our listeners understand that.
okay. So how about oral buprenorphine?
In which
Well,
species?
I would be
Cats and dogs.
remiss if I didn't mention that the papers in which it was originally described were given oral transmucosal and then sampling the jugular vein. So they probably overestimated plasma concentrations to some extent.
That's a very interesting insight. I like that.
That's fair.
Yeah, that was shout out UC Davis, shout out Bruno Pippendop.
I mean, that's the type of nitpicky bullshit that we're accustomed to with Dr. Bailey. But
Lucy
no,
Davis.
that actually, that's a good point too.
It
Especially
is.
if it is filtering down from Bruno, is like the pharmacology.
I
Yeah,
feel like he might have
Okay.
repeated that experiment and looked at like arterial concentrations to like get a better, like to do it right. And I think they were overestimated marginally, but I think they were still potentially therapeutic. I mean, I'll tell you, it works in my cats. Both
yeah, no,
both
I
Bubba
think
and Lucy, they love the buprenorphine. They're fiends.
it works. I mean, I think it's good.
I like buprenorphine in cats specifically.
Yeah, I agree.
I think
How
it's
concerned are you? Granted that again, we usually are not the one prescribing this, but you know, are we worried about diversion?
Absolutely. I mean, so like I don't know what the laws are like where you all practice, but I do know some colleagues who practice on the West Coast who do have to get fairly extensive opioid histories about their owners before they can prescribe them oral opioids.
Are we talking about buprenorphine specifically? Oh, okay. No, I mean, buprenorphine is sometimes used in human medicine as the weaning opioid for severe addicts, right? Like if you're coming off heroin or what have you, buprenorphine can be an alternative to methadone, right?
No,
So,
that's fair. But that's
yeah,
why I'm like, I think we're worried about diversion from a legal standpoint, but I think that from a practical standpoint, it's
I'm not
probably
that worried.
the
Yeah.
same way, when people ask about, hey, I'm worried about keeping a schedule 2 in my clinic. First off, I always tell them that, doing poor
What doing
analgesia,
anesthesia?
the diversion is not an excuse for shitty analgesia.
For sure.
And the answer to diversion is a fucking camera above the lockbox. But methadone technically, what diversion do you have? Like, what do they do with it? Do they get better? Like, you know what I mean? Like, who's gonna steal methadone? You know what I mean? Like, so I don't know. I think that we're worried about it from a legal standpoint. There is a chance, but like, I think that probably we're a little bit overly worried, right?
I mean, I think the other maybe little like thing to drop in here is they're also dog shit for anything but acute pain management. The opioids,
What do you mean?
like I mean, most of the information from humans is that like opioid use in chronic pain management is essentially worthless and does not like it may improve pain scores, but it doesn't actually improve like any social scores on chronic opioids get, and it causes them to vomit. So you have you have statistically significant changes in pain scores, but their lives aren't actually better and they throw up more.
Oh, no, that's fair. I'm just saying, the diversion from recreational purposes.
Oh, I meant like as using opioids in our patients, like short term, short course kind of thing, not long term. So like, I think I guess maybe where I'm coming at it from is like they're kind of dog shit in our patients anyway, in a way.
Like you're saying, sending the patient home with opioids is not good.
I mean, if I had to only choose one drug to send a painful patient home on, it's not an opioid, that's for sure.
Fair.
I was only allowed one.
Well, which one did you pick?
Okay. Fair.
Like when I saw those pain patients, I would tell them opioids are a pulse therapy. We'll do a couple days. If the dog has a bad day, we can do a couple days, get them through it, and then we're stopping at cold turkey.
I think that's how most people use it, though, right? Like, even when you send home or a buprenorphine, you don't send them home with a fucking bottle,
Oh
right? You
yeah, for
send them
sure.
home
But
with
like,
like 3
yeah,
doses.
yeah.
You know what I mean? Like,
But those patients who like have a chronic condition like osteosarc or osteoarthritis or whatever,
oh yeah, fair, sure.
they like I guess that's where I'm coming at it from is like their analgesic efficacy is probably like
Yeah,
mild to
it's for
moderate
acute pain.
in the outpatient, and then on top of that in dogs, like what are our options? Like what are you giving a dog for an oral opioid?
Tramadol?
I I always use the a paper from Butch Kukanich that was like showed that they had pretty reasonable plasma concentrations of morphine when administered codeine because of their metabolism. So like that I think has the strongest evidence, but I don't know if we actually have the efficacy evidence of that drug then being used, unfortunately. But
Yeah,
getting codeine can be a real challenge for
it
sure.
is hard.
It's like Schedule 2, you got to write a script for it
Yep.
and this and that. So like it does create a lot of headaches, unfortunately,
Yeah,
for prescribers for sure.
yeah. Well, yeah, I think we covered most of the.
We
We
didn't
covered.
delve into GABA, but we've talked GABA before, so.
That's true. We did not get to GABA. Alas, GABA is. I mean, I mentioned it casually that some people love it and some people hate it. You know what else we didn't mention? The most important part of this podcast: hot dogs. Anyone had a good hot dog recently?
But I sat for 3 hours at fucking Costco getting
How many hot dogs you put down?
0. But I
What?
had so many hot dogs around me.
Oh my god. We've been going to Home Depot like every weekend, and they got the hot dogs there, and I get Fix and Frank's fucking like almost every time. Carol was
Usually
like, "You
not
know
the
what I
way.
could go for? A hot dog." We had hot dogs multiple weekends in a row. I am living the dream right now. Let me tell you.
Bailey, what is your Lipitor dose? Like, honestly.
And summer's coming up.
Hot
It's gonna
dog
be,
season.
hot dog central.
I honestly think, Bailey, like, I don't know, when you turn 50 or like, I don't know, like an important wedding anniversary, like you should devise like a global hot dog tour where you go on a trip and you just hit the major hot dog spots and then like make it a show or write a book or something. Like,
Let me tell you, every time I'm out, every time I go to a foreign country, I basically try and find a hot dog to eat.
I see
Because
your
we're
Instagram.
aware.
yeah, yeah.
I see your Instagram stories.
Get ready. Get ready.
Oh my god!
Mm.
All right. Well, this was a good chat, guys. It was
Yeah, I
cool.
think it was. Hopefully, someone can take something away from it other than like we hate all the oral options we have available to us.
I don't think that's what we said at all. I
Yeah,
think
yeah,
It's challenging, don't get me wrong. And it's
yeah, for
really
sure.
extra challenging too if there's some sort of clinical preclusion for the NSAID, because that's really like, I think where the three of us all tend to start.
Yeah,
And
that's
it's nice to hear that we're not like super uptight about the NSAIDs, because some people, like I said, like they withhold where I find it inappropriate from the point of view of patient welfare. But yeah, I mean, it is hard. And we didn't get to Grapaprant, for example. Like
oh yeah.
we didn't have a
Well,
chance.
I'm coming up again.
Yeah, and actually, there was something earlier that you said, and I was like, "That's my next topic." Like right there is going to be that.
Oh, what was it?
I can't tell you. Then it's not a random anesthesia topic. Then it's a premeditated anesthesia topic, which ruins all of our branding, guys. Like, yeah, so I can't tell you, but
What a branding with hot dogs. Am I wrong?
the random hot dog podcast.
Ah,
It's basically
there you
getting
go.
that at this point. But yeah, no, I can't tell you. But I was totally like, oh yeah, that's what I want to talk about next time.
I got a good topic too. I'm just brewing it. All right. You guys have a good night.
Okay. Thanks,
Bye.
guys.
Bye.